So I'm Jeff Calvert. I'm the Associate Director for Clinical Quality at the World Trade Center Health Program. And it's my privilege to introduce today's webinar, which is titled Aerodigestive Disease in the World Trade Center Exposed FDNY Cohort, Validation of Biomarkers and Defining Risk to Tailor Therapy. So it will be given by Dr. Anna Nolan, who is a well-respected clinician and researcher. I found it interesting that she did all of her training in New York City. So she obtained her medical degree from SUNY Downstate, which is in Brooklyn. Then she did her internal medicine residency at St. Luke's Roosevelt Hospital Center in Manhattan, followed by a fellowship in pulmonary and critical care medicine at NYU. And she's currently a professor of medicine at NYU and has been practicing for over 20 years, and is also a medical officer for the fire department of the city of New York, or FDNY. Her research interests and that of her laboratory include the prevention and treatment of lung disease, the impact of environmental exposures on the lung, and the use of machine learning to improve the diagnosis and treatment of disease. And I believe her talk today is based on work performed under a NIOSH research grant that commenced approximately 3 years ago, which she has listed on this slide. It focuses on gastroesophageal reflux disease, or GERD, one of the most commonly certified conditions in the World Trade Center Health Program. And as you likely know, GERD is one of the conditions that has a maximum time interval, meaning that in order to be eligible for certification, the disease had to manifest within 1 to 5 years after the cessation of 9/11 exposures. So Dr. focuses on the overlap between GERD and lung pathology and lung pathophysiology. And I think today's talk promises to be extremely interesting and enlightening. So without further ado, I present Dr. Nolan, who will share her findings on aerodigestive disease in the World Trade Center exposed FDNY cohort. Take it away, Dr. Nolan.
All right. Thank you very much for that lovely intro. I feel really old also after all of that is said and done. Yeah, this topic is really important. And you're right. I mean, in that it is a time limited, there's a very short period of time from the exposure to the time you can be certified. So, and in addition, I was very interested to kind of study this because I know my patients that have lung issues also often have GERD. So I was trying to understand the relationship and how to best help the patients. So the grant was funded about 2.5 years ago. And I'd like to move on to my next slide, if possible, if I can do that. Yes, I can. So basically, the first slide is a broad overview of what I will be sharing with you today. And I will discuss the clinical concerns of diseases that affect both, that include reflux, Barrett's esophagus, and asthma. We will discuss the Trade Center exposed populations and some of the prior biomarker work and some of the papers that we've more recently published, trying to gear up to do this study because we wanted to understand what was out there already. So we published a broad paper on prior work. We will discuss the clinical questions we're asking, go through the aims briefly, and discuss what kind of biomarkers we're focusing on, and show you some of the preliminary work. And this is all available on clinicaltrials.gov. So why is GERD so important? It's a global burden of disease. The incidence and prevalence of this has been increasing over the last few years. Globally, GERD affects about 20% of the US population in the US. It's very costly, and the procedures to diagnose these conditions are also highly invasive. They include endoscopies, biopsies, and there are potential for bleeding, perforation, and other risks. So it's kind of hard to do these very often, even though patients continue to have symptoms in between their endoscopies and treatments. And also, reflux can lead to Barrett's esophagus, which is a risk factor for cancer. So, GERD and environmental exposures. Not only are the Trade Center firefighters have been exposed to significant environmental exposures, but we all are. And those of us who are living on the East Coast, even on the West Coast, have more recently been exposed to wildfire smoke and significant burden of smoke and particulate exposure. So these next two slides just list, the basic exposures and a little bit of the literature that kind of associates development of reflux, Barrett's esophagus, and other diseases of the GI system with these environmental exposures. So we've done a broad search in the literature, and there are various papers all over the world, various countries, including the trade center exposed populations, that indicate that the GI system is greatly affected by these environmental exposures. So it's an active area of research. Oops. It's an active area of research. And basically, we're all trying to confirm a causal relationship between air pollution and environmental exposures, develop mouse models, cell culture models, and such. We try to understand the mechanisms more so. So what are we studying? We're studying diseases both of the upper airway and the GI system. So our study attempts to find non-invasive ways to diagnose or even distinguish GERD from respiratory disease, in addition to characterizing the overlap that may occur between the lungs and the GI system. And it's difficult to diagnose these patients because they often present in a very similar way. They have a cough, for example, very nondescript. So it's often a diagnostically challenging thing. I will go through this image a little bit more a little bit later, kind of tells you what we've been looking at and why we have chosen these biomarkers. So clinical presentation, you know, our firefighters, similar to the other populations that have been so greatly exposed and were ill from their trade center exposure, they can develop not only loss of lung function, change in lung function, they can develop asthma. They also often develop GERD, cancer, and other diseases. So this is taken out of the more recent book that has come out of the FDNY that kind of gives a broad overview and update of what's going on with our populations. Here, for example, you can see all the way on the left-hand column in this this XY chart that reflux, similar to many of the other diseases, is very much linked to exposure. So those individuals, the morning of 9/11, have the greatest number of those individuals who have developed reflux disease. And if you're less exposed anytime after 9/24, you have a less of a chance of developing this condition. This kind of is par for the course. This is also from the same book, and it's, you know, it covers up to 20 years or so of data up to 2021. And basically, as you can see, GERD was very common. It occurred in 41% of people in year one, and still similar 20 years later, also exists in a similar percent in the population. So it's a very valent, very important disease to continue to look at in these patients. Sorry, my mouse is very sensitive on my Mac, so it keeps switching. So another point of just to share with you how important reflux is. As you can see, the number of certifications is very high, both for reflux disease, lower airway disease, and also upper airway disease in the first responders that have been exposed. So clinical questions. Why are we looking at what we're looking? We want to identify subgroups at risk. In this case, we're looking at those that that have developed or are at risk to develop both GI disease and also lung disease. And we want to identify the subgroups of interest, which I will define a little bit later in a couple of slides. And we basically are going to try to look for these non-invasive biomarkers. How can we assist these patients to understand how symptomatic they are right now, how much more treatment they might need, and how their lung disease might be interacting with their disease in their stomach and other aspects of the GI system. So we developed a few aims that we got funded, and we are grateful for that funding so that we can look at very important clinical questions. We wanted to validate prior biomarkers that we had identified in this population. We had published a paper that I will briefly tell you about first. And these biomarkers are not just in the serum, but they're also clinical biomarkers. Like what other treatments might they be on that might make it more at risk for them to develop GERD, for example, or Barrett's esophagus. And then we wanted to validate in a sub-cohort design these biomarkers, and I will define exactly how we randomly selected that 20% of the population that we will use in our subsequent aim. So As I mentioned, we had published a pilot biomarker study several years ago, prior to the funding of this grant. In this study, we truly realized that these patients have been greatly affected. As you can see, the paper was published like in 2018 or so. So the data set goes up to 2016, 2017. I believe it's covered partially by the faces there on the side, but that's okay. And so these trade center exposed firefighters have been followed longitudinally. As we know, by 2005, 44% of the trade center population had developed GERD. It's 8.2 times its pre-9/11 prevalence and 2.2 times the prevalence in the US population. And much of the cohort had coexisting airway disease. So this interdependence was important and the focus of the pilot study. As you can see, we had published a bunch of papers prior to this, and we had some biomarkers available, and we had gotten data in collaboration from the FDNY that has this cohort, and we looked at their biomarkers. We did this primarily because we were really curious what pathways might be important and how we can best approach studying this. And after we analyzed a very small number of individuals that we had data on, and we also had identified whether or not they had GERD through looking at their EMR and medication usage, we published a paper where we saw that TNF alpha was one of the biomarkers, as was C-peptide, and there were other biomarkers that were also specific for Barrett's esophagus. Now we realized this is a very small pilot, and we use this as partially a way to get further funding to look at additional biomarkers that might be interesting. Also, the GERD cases in this population had similar lung function, DLCO, and bronchodilator response and long-acting beta agonist use as their controls. So there really wasn't much difference, at least in this smaller population, as to what their lung function might have been at the time. So we were still, trying to understand this in a much broader population. So, and A1B is basically to validate risk of respiratory medication use in patients with airway hyperactivity on GERD, Barrett's esophagus, in the trade center cohort. I just want to take a moment to say, defining these conditions is often a little bit challenging, especially for GERD, because it does require an invasive test. So in response to critique and in response to consulting with two folks here at NYU who specialize in GI and associated conditions, we, in addition to looking at their certification history and medication history, and then once consented, asking the patients if they had GERD or Barrett's esophagus, we are trying to capture their information in regards to their biopsy and trying to really, define GERD in a more restrictive way using the standard criteria of being an LA grade C or D and or having strictures or Barrett's esophagus. And then in regards to whether or not they have asthma, looking at their methacholine studies and their PFT studies and their bronchodilator responses. Okay, so methods. We have presented our work at several conferences recently. One CHEST in 2023 in Hawaii, which is a nice place to go. And basically, we were first interested in presenting how we defined our population. And the theme for the rest of this presentation will be that we're looking at those with GERD versus those with Barrett's only, and an overlap of GERDs and Barrett's and lung disease, versus those that have airway hyperactivity alone, and comparing those other four groups to individuals that do not have any of those conditions, which are exceedingly hard to find. And for the initial first pass at looking at their medication use and other information, we are looking at whether or not they had been diagnosed with GERD just purely on looking at their data provided and not necessarily having access to their biopsy reports and such. So what we found, interestingly enough, we were trying to replicate our prior work, is the use of medication and how it might affect these patients. Most of these patients were obviously Caucasian, male firefighters. Mean age at their exposure was 39. And about 60% of these patients had GERD as a diagnosis in their record. Specifically, I think I have to move this thing. I don't know if you're seeing the same I'm seeing. SABA use was associated with an increased odds of developing GERD by 4.08 odds, and these were all significant. And the use of short-acting beta agonists or SABAs was also associated with the development of Barrett's esophagus. Now, being highly exposed, so arriving at the Trade Center site on the morning of 9/11 increased your odds, so gave you an odds ratio that was 36% versus and 41% respectively for the diagnosis of GERD and Barrett's esophagus. The other medication that we know that can affect reflux and other associated conditions is the use of steroids. So specifically in this abstract, we studied the use of steroids, and we found that it was associated with increased odds of developing GERD by 4.65 and Barrett's esophagus by 2.27. And Trade Center exposure, the most highly exposed when compared to the other subgroups, also increased your odds by 40.8% and 43% respectively. So we see this like potential interaction, or I wouldn't say interaction, association with use of certain medications with development of the conditions we're interested in. Okay. So conclusion of this abstract was in populations with high particulate matter exposure, SABA and steroid use associated with high risk of GERD. Further investigations to the overlap of GERD and Barrett's esophagus and airway hyperactivity can help distinguish phenotypes of disease. Future studies will include assessment of other inhaler use, aerodigestive disease, and analysis of serum biomarkers predictive of GERD or associated with GERD currently in the populations that we're enrolling. So AIM2, which is I will spend the bulk of the time on, is meant to characterize the overlap of pulmonary pathology and reflux. Now, basically what we're trying to do is we're trying to bring back a small proportion of individuals in each of those subgroups. So those with AHR, GERD, AHR plus GERD, Barrett's esophagus, if that's their only diagnosis, and controls, and quantify non-invasive measures of inflammation. Now, we have been enrolling over the last year or so actively once we were able to do the other portions of the grant. And basically, we have been studying salivary pepsin, serum biomarkers. The metabolome will also be looked at. I'll show you some preliminary data there. Fractional exhaled nitric oxide, exhaled breath condensate. And we are deploying various questionnaires through REDCap to try to understand their quality of life and how they view their symptoms related to GERD. So we want to phenotype and quantify any underdiagnosis, treatment, and treatment efficacy, and trying to add more biomarkers to our multidimensional biomarker set. So the overall hypothesis is that non-invasive biomarkers of airway disease, Barrett's, and underdiagnosed reflux non-invasively can identify, these biomarkers can identify a population of those with GERD and Barrett's esophagus that may benefit from further treatment. So this is our figure, and we're going to measure several questionnaires, which I will go through in detail. They're nasal and esophageal, they're posterior pharyngeal microbiome, exhaled NO, exhaled breath condensate, histamine levels, salivary pepsin, and blood will be collected for biomarkers and metabolomics and storage for future use. So this is the overall pathway. I'm not going to repeat all of that, just kind of give you a broad overview. So we're going to recruit, consent, have them come in after they've signed consent, obviously, but also most of this questionnaires will all be done remotely, so they don't have to come in, so they don't have to risk coming into a hospital and be exposed to infectious diseases. And ideally, we'd like them all to come in for one visit so we can do a lot of in-person assays, which I will go through. So populations have been defined, as you see here. Of the people that we brought in so far, 42% of those individuals, so we've enrolled a little under 50 subjects, and most of them have done their questionnaires, and some of them have come in. So we're hoping to bring in the rest of those subjects. So 42% of the subjects that we have spoken to have GERD, Barrett's esophagus, and have with GERD, Barrett's esophagus, we're also certified for asthma. 71% of the subjects with airway hyperactivity were also certified for GERD. And medications, GERD subjects were less likely, although not significant at this point, to be on LABAs, long-acting beta agonists, and short-acting beta agonists and controls. And 12.5% were on LABAs, and 33% were on short-acting beta agonists. In regard to the airway hyperactivity subjects, SABA use, short-acting beta agonist use was significant compared to controls, which makes sense. But they were less likely to be on long-acting beta agonists and H2 blockers. So there was a significant difference in proton pump inhibitors, H2 blocker use seen across the groups thus far. So I mentioned earlier that we had published a systematic review. We did this mostly because we went through the process of looking at this, and we had our study registered officially as a real systematic review with hypothesis and plan. We wanted to see what was out there because we wanted obviously to make sure that we weren't repeating anybody's work, or at least not doing a better job. So we registered this with Prospero. We looked at hundreds of articles that we were able to identify in relationship to articles focusing on these non-invasive biomarkers of GERD specifically. And we looked at the risk of bias of these studies because we obviously wanted to make sure the quality that we were looking at, and we published this final review paper. Salivary pepsin, one of the biomarkers that we said we were going to look at, was the most studied biomarker that had significant sensitivity and specificity for GERD. So we wanted to see if our work similarly showed this. We're not quite there yet, but we have some promising data to show. And serum assessment showed elevated levels of TNF alpha in both GERDs and Barrett's. That was mostly our work and one other paper. And exhaled breath volatile sulfur compounds and acetic acid were also associated with reflux. Other folks have been looking at the oral microbiome. And so these are the organisms here that we're considering looking at, obviously, also. But, a lot of these studies suffered from biases, which I will go through briefly on the next slide. So we used a very systematic way of looking at these biases. And as you can see, lots of the biases were broken down into two groups: risk of bias assessment for cohort studies and risk of bias assessment for case control studies of the final papers that we looked at. And many of these studies did have issues in various areas of biases, specifically how comparable they would be to other cohorts. They were tended to be done in very small cohorts that were very specific to one type of group in one part of the world. So we wanted to make sure that we broadened this in our work. Oops. So back to our study design, and these are all the folks that are helping to do this project. These folks here are gastroenterologists. Everybody else is in my lab. This is Dr. Liu, who is a population health biostats person who works with us on all of our studies and help to design the study. So I just want to briefly go through the questionnaires that we're doing. So the next part of the talk, we've broken up into questionnaires and then the in-person visit. All our questionnaires, we like our patients to do this remotely. Of course, if they're unable to do this, when they do come in for their in-person visit, we can help them fill out their questionnaires in person. But most have been able to do this remotely. So we want to focus first on the questionnaires that are specific to gastrointestinal symptoms. We asked our experts, we read the literature, and we reached out to various folks and other institutions. We came up with using these two questionnaires. which are called Patient Assessment of Upper GI Disorders Quality of Life, and the same acronym with their Symptom Severity Index. So PAGI-QoL and PAGI-SIM. PAGI-QoL is specific to upper gastrointestinal disorders. It's reliable, has been validated using other publications. And the validation studies observed a significantly lower quality of life score individuals with impairment in daily activities from upper GI symptoms in the original papers, and assess quality of life in GERD, dyspepsia, and gastroparesis. Now, not too many of our patients have gastroparesis necessarily, but the other two symptoms definitely they do have. And PAGI-SIM was developed in parallel and often used with PAGI-QoL, and measures symptom severity in patients with GERD, dyspepsia, and gastroparesis, and intended to cover the main symptoms grouping for the conditions that were studied. So the data thus far. PAGI-QoL it's available in multiple languages, consists of 30 items. It's a 6-point Likert scale, 0 to 5, with 0 being all of the time, and the 5 being none of the time. Items are grouped into 5 dimensions: daily activities, clothing, diet, food habits, and so forth and so on, relationship and psychological well-being. Total score is an average of all dimension subgroups, and final score can range from 0, lowest quality of life, to 5, highest quality of life. So we broke this down into each of the subgroups, subscales, and the total score. Significantly, we found lower PAGI-QoL total scores observed in GERD subjects compared to their controls. So that's the total score. We didn't really find the subsets to be that significantly different amongst themselves. Next, PAGI-SIM similarly is a 6-point Likert scale, 20 items, consists of 6 subscales: heartburn, regurgitation, fullness, nausea, vomiting, bloating, upper abdominal pain, and lower abdominal pain. And the final score is the average of all subscale scores, and can range from 0 to 5. Higher scores indicate higher severity of symptoms. So these, as you can see, these numbers are on the lower scale. So they're kind of complementary. One scale, 5, you're healthier, and the other one, 1, you're healthier, or 0, you're healthier. There were higher PAGI-SIM scores observed, but not significantly different when comparing GERD subjects compared to controls. All the other comparisons were insignificant thus far. Respiratory assessment. We looked at health-related and health-related quality of life. We've done 3 questionnaires: HRQL, SGRQ, and SF36, many of which are used by our cohort and other cohorts for various assessments. All these questionnaires have been validated, assess symptom control. So, doing that. Okay. HRQL is a 14-item questionnaire, consists of 3 modules: core healthy days, activity limitations, and healthy days symptoms. The unhealthy days from the core healthy days is the one that's quantifiable. And basically it's the number of unhealthy days in the past month that you've experienced. So core healthy day module, the higher unhealthy days observed among AHR and GERD subjects compared to their controls, insignificant at this point with our current numbers, where we will continue to accrue the data. And then generally we're looking for other ways to kind of show this. We did like this radar spider plot of looking at numbers of individuals that kind of answered these things. Activity limitations. So no subjects have stated that due to their impairment, they have needed help with personal care. And only one subject with a walking problem has stated that due to their impairment, they need help with routine needs. So this data is in an abstract that we've submitted. Sorry about that. So SGRQ, specific to patients with COPD. Consists of 2 parts with 3 subscores. Part 1 is the frequency of respiratory symptoms. Part 2 is patient current state, and produces 2 subscores: activity and impact score of how your condition has impaired your personal and social life. And scores are percentages of the sum of the answer weighted out of the maximum possible score. So it's 0 to 100. Higher score overall is equal to greater impairment of respiratory health. So good thing to see that our patients are not that greatly affected. We do see higher symptom impacts and overall scores observed in the GERD, Barrett's, and esophagus subjects compared to controls. Higher, not significant at this point. The other comparisons, if you look at those that have asthma compared to the folks that don't have asthma, you don't see higher numbers or even trending towards higher numbers. The SGRQ subscales, again, looking at a total score, symptom severity. Again, this is just similar. We comparing those with AHR versus controls, they're insignificant. The total score is a little higher compared to controls, those individuals that don't have it, but none of this is significant at this time. And SF36 is the next and final quality of life questionnaire that we're doing. These are 36 questions. They do assess physical health measure, physical function, role limitation, pain, general health. Mental health measures are also included, and each subscore is an average of respective weighted answers. It also goes 0 to 100. Higher scores are better health. And these are, we're just showing you reflux versus controls, and these are insignificant when comparing the 2 groups. What we do see is that there is lower emotional well-being and pain, and significantly lower energy, social functioning, and general health scores observed among GERD subjects compared to their controls on the SF36. There's also lower general health scores among airway hyperactivity subjects compared to their controls. This is just one of the subsets of the questions that we have in SF36. Then for those that are able to come in and who can continue to come in over the time of the study, we try to make it as reasonable for them to show up when they're in town, for example, because some of them don't live close by. We do offer a variety of non-invasive tests, so I'm going to go through each of them briefly. They include exhaled breath condensates. This allows us to potentially identify non-invasive biomarkers, and then we can also store this exhaled breath condensate away. Basically includes, there's a chiller that kind of fits over this tube. Oops, it fits over this tube, and the person sits and calmly just breathes into the mouthpiece that's available to them, and they can take breaks. And we do about 10 minutes, and we get between 1.5 to 2 mLs of exhaled breath condensate. And be careful for them to actually, breathe out and in with their mouth, because sometimes they don't. You don't get as great a sample. But as long as the device is well chilled and we're watching them and being there for them during this 10-minute process, we've been able to get very nice collections. Previous studies have found significantly increased levels of exhaled breath pepsin, something we're interested in looking at, in subjects with obstructive lung disease and GERD when compared to healthy controls, as other people's data. So decrease in pH, histamine, and adenosine may be promising objective markers in looking at their exhaled breath condensate. As I mentioned, we can get a little bit more than this, definitely way more than 0.5 at this time, because we do about 10 minutes. Samples are processed and distributed and aliquoted and frozen away at -80. We do an immediate pH measurement in each sample pre-post. We basically have to get rid of any air that might be trapped in the sample using argon gas. So we have argon gas delivered to the lab, and we do this prior to any pH measurements. Thus far, what we have found is lower exhaled breath pH is seen in GERD and Barrett's esophagus subjects when compared to controls. So the p-value is significant. And airway hyperactivity subjects, thus far, it's non-significant. So it seems to be more of a specific thing in GERD patients. We are collecting, but haven't done anything with it yet. Their oropharyngeal and nasopharyngeal microbiomes. These are collected in OmniGene, DNA, these specific things that we purchase. It's relatively non-invasive, just similar to a COVID test, but not as far back. And we standardize the length of time and the location that we examine. There are other papers where combining oropharyngeal and nasopharyngeal serves as a surrogate for lavage, which we do not do on these patients. Studies have found a difference in nasopharyngeal microbiome data in various lung diseases, specific to what I just said. Doing those two samples together are important compared to those without lung disease. We do place the swabs in a vial, it's stabilized, and we do use glutinase K to process the samples. And they're incubated briefly at 50 degrees and now prodded for future determination. We also measure fractional exhaled nitric oxide on these patients. Some people use this clinically already. Nitric oxide is a marker of airway inflammation and epithelial damage. Levels have been found to be increased in obstructive airways disease, and might be able to be used to differentiate airway inflammation from obstructive airways disease versus non-pulmonary causes such as GERD, potentially. And might be also useful for underlying identification of airway hyperactivity, exacerbating symptoms of GERD, potentially. So we found higher mean measured exhaled NO levels in subjects with GERD Barrett's when compared to their controls. Not quite significant yet, just higher. But this was not true in those patients that had asthma. So a little bit about metabolic syndrome characteristics, which we'll also go through, which has been very important to this lab's work. Metabolic syndrome, as you know, is having 3 out of the 5 characteristics of metabolic syndrome, which includes elevated blood glucose, blood pressure, triglycerides, low HDL, and elevated waist circumference and/or BMI. Prior studies have noted increased risk of GERD in patients with metabolic syndrome. So just briefly for this population that we have available to us that have come in, metabolic syndrome characteristics, significant difference was seen in the systolic blood pressures when GERD subjects were compared to airway hyperactivity and overlap. Higher mean fasting blood glucoses, because we do their basic clinical chemistries and CBCs and LFTs when they come in, and cholesterol levels. Higher mean fasting blood glucose levels was seen in subjects with GERD, Barrett's when compared to controls. And similar pattern was noted for BMI, triglyceride levels, and waist circumference. So another big test we do, we ship them off this pepsin test, and they collect the samples prior to coming in. We are looking at pepsin levels. The pepsin is a digestive enzyme whose precursor is pepsinogen, which is produced solely by the gastric cells. Salivary pepsin was the most studied non-invasive biomarker in our systematic review, and previous studies have shown sensitivity ranging between 40 and 72% and specificity between the 80s and high 90s%. Subjects are sent these kits. We want 3 samples from them prior to breakfast, 1 hour after lunch, 1 hour after dinner. Samples are processed and measured using this PepQ and this lateral flow measure. And you can quantify pepsin as in a nanogram per ml quantity. Salivary pepsin was significantly increased in GERD Barrett's esophagus subjects when compared to controls. And positive pepsin, so some papers have said if it's above 16, was seen in about 35% of our subjects. Not all of them were actually already diagnosed with GERD. So that's an interesting thing to consider going into the future. We do cognitive assessments on these patients. We do this primarily because cognitive assessment is important in the context of the study, as previous studies have found increased risk of dementia and accelerated cognitive decline has potentially been associated with GERD and airway hyperactivity. And some studies have noted a higher incidence of newly diagnosed dementia in individuals over the age of 45 using PPIs. So we do them a MOCA on them in person, and everybody who does this is certified to do the MOCA, and a mini mental status exam on the subjects who have come in. And each of these tests slightly different criteria, and basically normal for a MOCA is considered anything greater than 26 out of 30, and for a mini mental status exam, normal is considered greater than 24. Oops. Alrighty. And that's about it. We haven't found any significant differences in the populations thus far. So aim 2, so 2B. So basically, we are eventually, after we accrue the appropriate number of individuals, our big plan is to understand, to put together a multi-dimensional model that best predicts who is most likely to have reflux GERD. So this prediction model will include non-invasive biomarkers and will help differentiate trade center associated airway hyperactivity, GERD, and Barrett's esophagus. We predict that specifically GERD and Barrett's esophagus cases will have higher pepsin levels, express distinct exhaled breath and metabolic biomarkers compared to the GERD and non-GERD and airway hyperactivity patients, and may benefit from augmented therapy. So, summary of everything we have found thus far in our population that we've enrolled is that lower exhaled breath pepsin, and higher exhaled NO are observed in GERD Barrett's esophagus subjects. Lower exhaled breath condensate pH and higher exhaled NO also observed among proton pump inhibitor users than non-users. Previous studies have validated exhaled breath condensate as an appropriate representation of airway pH. And other cohort of patients with chronic cough, those whose cough responded well to proton pump inhibitors, also had lower exhaled breath pH versus those whose cough failed to respond. So this is support for the use of exhaled breath condensate pH testing as a non-invasive diagnosis of acid reflux as a cause of cough, potentially. And assessing exhaled breath pH and exhaled fractional exhaled NO in addition to a patient's use or response to PPI shows potential to diagnose reflux. Also, lower exhaled breath condensate pH and higher exhaled NO scores correlated with worse PAGI-QoL and PAGI-SIM scores. This kind of figure here gives a brief overview of what we found. So we have tried to do a little bit of machine learning. I will 2 more minutes to talk. And basically, machine learning, we're trying to optimize a biomarker set associated with diseases of the lungs and the GI system. So we know that these conditions I've told you already are quite, cause a lot of adverse health and quality of life issues. But studies are limited in understanding the link between AHR, GERD, and Barrett's. So we're trying to look at these biomarkers. This multidimensional large data sets pose unique challenges. So we're trying to, assess their metabolome, but using the metabolome, we know we need to use more focused and slightly different ways of assessing the differences in the population. So we're trying to overall improve speed, precision, and accuracy of data mining through use of random forest. We've published several papers prior to this, which I could include in some future talks. And we're using this gradient boosted tree modeling to identify metabolite classifiers of AHR, GERD, and Barrett's esophagus. So we had previously assessed the metabolome on this randomly selected 10% of the cohort, which is now embedded within the 20% random selected cohort that we're studying here in follow-up. And these metabolite serum profiles were analyzed by mass spec, and peaks were matched using in-house public libraries. And as I mentioned, we're using the random forest technique. So, big figure, airway hyperreactivity is all the way. Let's see if I can move this slide somewhere. Airway hyperactivity is all the way in panel A. Panel B is GERD, and panel D should be Barrett's esophagus. So for all those individuals that have already had metabolomics done, we looked at their refined profiles for all cases of airway hyperactivity, GERD, and Barrett's esophagus, and we plotted the values as a log 2-fold change. So this is a mean decrease accuracy. So plotted along the x-axis, and the pathways and/or analyte metabolites are plotted across the y-axis. And the overall classification error of the model and area under the curve are within this confusion matrix. And basically, those metabolites that are most important to the model are at the highest point in this graph, and those that are less important are at the lower portion here. So, for example, in regards to airway hyperreactivity, we see that decreased mesobilirubinogen compared to controls was seen. The overall classification of this model was 95, which is quite high. In regards to GERD, we see a totally different set of metabolites. These metabolites are mostly estrogen, testosterone metabolism driven, and they include the list here. There are other pathways also important, but we found it very interesting that they're very different metabolome profile that are found important. The area under the curve of this model is 0.88. And in regards to Barrett's esophagus, we didn't see any sex hormone related metabolites identified, very different than what we saw in GERD. But we did see metabolites of things patients might have been taking for symptom relief, such as a Tylenol and antibiotics for key exposures that were key metabolites that were seen in that population in regards to GERD and Barrett's esophagus. There were no overlapping metabolites identified cases of GERD and Barrett's esophagus. And the area under the curve of the BE mean decrease accuracy red forest curve was 0.93. Again, we have to further finish the analysis, but we find this very interesting. So I think I'm almost done with my time. So the differential expression of metabolites, heme oxygen, HO1 metabolizes heme into metabolites, and sex hormones and exogenous therapeutics were linked to GERD and Barrett's esophagus. And there are various other theories that we have as to why these things might be important, but basically all these metabolites and biomarkers are potentially going to show us which pathways might be important in these very different disease processes that often show up together in a patient and make it difficult to treat these patients. So I'd like to thank everybody who has worked on all of these things. A very long group of individuals. We do use the cluster here at NYU to do all of our large data set analysis and various individuals in the lab. Some of the folks that were here this summer working with us, and my children. And if you have any questions, I'd be happy to take them.
Thank you so much, Dr. Nolan.